afternoon, everyone, and thank you for joining us. My name is Samantha Holloway. I'm a Reader and Programme Director in the Centre for Medical Education, School of Medicine, based at the College of Life and Biomedical Sciences at Cardiff University in the UK. I'm also the Chair of the Education Committee and Teacher Network of EWMA and serve as the President-elect of ISTAP. Together with Kimberly LeBlanc, I'll be the moderator of this webinar. Would you like to introduce yourself, Kim? Kim, can you unmute?
That would help, wouldn't it?
Okay.
Thank you, Sam. And welcome everyone to our webinar. My name is Kim LeBlanc, and I'm the Academic Chair for Nurses Specialized in Wound, Ostomy, and Continence Canada. I'm also an adjunct professor with Western University and an affiliate lecturer with McGill University Ingram School of Nursing. And I currently serve as the treasurer for the International Skin Tear Advisory Panel.
Thank you, Kim. This webinar is the first in a two-part webinar series focusing on various aspects of skin tear prevention under the title, The Science and Practice of Skin Tears. The webinar will be recorded, so you'll be able to watch the webinar on demand. The recording will be available via the EWMA website within a few days. The 5 speakers we have here today will speak for approximately 15 minutes each. After this, there will be time for questions to the speakers. Please note that you can type your question in the Q&A box anytime during the webinar. Feel free to write the questions in either your native language or English, as we're lucky to have different speakers with different languages today.
Before we begin, we wish to thank our sponsors, Molnica and Essity, who kindly supported the Skin Tears Prevention campaign in this webinar series. The supporting companies have not had any influence on the content of the webinar.
So I'm now pleased to introduce the presentations and welcome the speakers in today's webinar. Our speakers in this webinar are presented on the screen for you. They are Jan Kotner, who will be speaking on the etiology and pathogenesis of skin tears. Julia Bresnay-Harris, who will talk about the pronation and the risk of skin tears. Hubert Vonnet will talk about pain and skin tears. Heidi Hevia Campos will provide insights on knowledge translation into practice tips for using the ISTAP skin tear algorithm in daily practice. And Anika Furi will be speaking on ProneTect practice guidance document, skin care considerations for the patient in the prone position. And so now on to our first presentation, and I'm really pleased to welcome Jan Kotner, who will talk about the etiology and pathogenesis of skin tears.
Hello. Welcome everyone to this webinar, and the topic of my talk is etiology and pathogenesis of skin tears. Etiology is regarded as a cause of a disease, so skin tears today, and pathogenesis, the way how a disease develops. But before we talk about both concepts, it is important to clarify what are we actually talking about. What you can see here, the first bullet, is a very famous, well-known definition. It says a skin tear is a traumatic wound caused by mechanical forces, including removal of adhesives. Severity may vary by depth, not exceeding through the subcutaneous layer. So although this definition is widely known and quite important, it is important to emphasize that there are many more concepts currently used for this phenomenon. And the problem is not only that we have different definitions, but that the concept of skin tears is also poorly understood, especially, for example, in the dermatology community. This may be also partly caused by the fact that it cannot be coded in the ICD-10, so the International Classification of Diseases, by the World Health Organization, and it can also not be coded in the ICD-11. So this is a current version. Anyway, there are concepts that do fit to skin tears, and there it is called laceration. Laceration at different body parts, so forearm, head, neck, and so on. So all this can be coded. And when you look where this laceration concept is classified, it is classified under the injury topic. What does the WHO understand by injury? Injury means physical harm resulting from interaction of the body with energy, mechanical energy in our case, in an amount that exceeds the physical tolerance. And I will come back to this later, because skin tears are the results if the skin or the cutaneous tissues exceeds their physical tolerance, or the tolerance is less than the mechanical deformation. What is also very important, it is always a rapid onset. So it's in a fraction of a second, there is a mechanical load, kind of impact damage. Prevalence is quite high, and I will not go into epidemiology today. And what is important for you to know, that what you can see here in the classification, for example, that most skin tears develop at distal extremities. So the back of a hand, fingers, arms, legs, and so on. Like many of these unwanted cutaneous effects, we can distinguish extrinsic risk factors and intrinsic risk factors. The extrinsic risk factors are very easy. In our case, it's trauma. Trauma, including the removal of adhesives, and at the same time, this is also the direct causal factor. So the etiology, the cause of a disease, is very easy. It is trauma, injury, mechanical deformation. But we have a number of intrinsic risk factors, such as age, medications, impaired mobility, dermal thickness has been reported, xerosis, cutis, and many, many more. The point is that no one will develop a skin tear just because he or she is old or taking certain medications and so on, but they increase the risk or increase the susceptibility to develop skin tears in combination with direct risk factors, trauma in our case. Age is really, really, really the most important factor. And because we are talking about a cutaneous event, if you like, it definitely makes sense to look at the skin structure and function. What you can see here on this slide is the structure of the skin. It consists of two layers. The epidermis, this is the upper layer here, and the dermis, which comes below. And then we also have a subcutaneous tissue or muscle or bone, so depending a little bit on the anatomical area. What is important for you to know, the dermis is perfused, so you can see the vessels here, you can also see hairs and so on, muscles, for example. The epidermis is not perfused. When we talk about mechanical deformation and mechanical properties, it is most important to look at the dermal properties, because really the dermal properties are do really matter here. So the epidermis also has an impact, but it's really minor. What is relevant regarding skin tears? The first one is the so-called dermal epidermal junction. This is what you can see here. So these are the kind of ridges where the epidermis and the dermis are tightly interconnected. We have a stratum papillare. This is the uppermost layer of the dermis. It consists of an open network of fine fibers, kind of loose structure, and it allows movement and deformation without rupture of these skin layers here. Then we have the stratum reticular, and this is really important to give tensile strength of the skin. It consists of a kind of 3D dense fibrous network. It mainly consists of collagen fibers and to a smaller proportion of elastic fibers. So, but both really interact with each other. We also have a kind of ground substance. This is a gel-like fluid, and this fluid allows molecular viscous sliding. So the fibers, it's like a sponge, and you have fluid in between. And when you compress, shear, deform this tissue, then sliding is possible. Now we look at skin aging and at some particular features. So first of all, what is very obvious, that we have dyspigmentation, how we call it, and this is really fragile aged skin at high risk of developing skin tears. And what is relevant here? First of all, it's atrophy. Here you can see ultrasound images of the epidermis, and what you can see here is the dermis. And the dermal thickness is substantially lower compared to younger skin. So this is one feature. Another feature is that what you can see here is these so-called pseudo scars. That means this is a result of repeated tiny injuries that do not completely heal. And what you can see also here is blood, or at least pigmentation, resulting pigmentation from extravasation of blood into the dermal space. And this is called senile purpura. What is also relevant is that the dermal epidermal junction, and this is what you can see here, becomes really, really flat. You can, by the way, you can also see that the epidermis becomes flat. And in addition to this, also the connection is less tight. So looking particular at the dermal epidermal junction, when you compare a younger aged individual to an older individual, here you can see how it is these ridges, the length and the number, but also of these ridges. And here you can see a flattening. And what you can see in red here, highlighted in red, this is a protein collagen 4, which is extremely relevant for the dermal epidermal junction. So we've got a flattening and a reduction of dermal papillae. And interestingly, this is especially relevant in photo exposed skin areas. This causes a reduction of the exchange area of epidermal nutrition. So remember, the dermis is perfused, the epidermis is not. We've got a reduction of entering molecules, what you can see in red here, and this goes along with a reduction in papillary fibroblasts. Fibroblasts are the most important cells in the dermis, and they produce collagen and also the other extracellular matrix. Altogether, this results in a loss of a structural integrity and a decrease of adhesion strength. And we have a huge body of evidence showing an association between aging and adhesion strength of the dermal epidermal junction. So we have a higher susceptibility to separation due to shear forces. When we look at the dermis, we have a number of changes as well. Again, fibroblasts, this is really the key cell in the dermis, and we have a fibroblast senescence, especially in these very aged, fragile skin. This results in a lower fibroblast density and a change and reduction of collagen and elastin. This is, by the way, what you can also see here, it is rather fragmented and coarsely distributed, and here in younger skin, it is really evenly distributed, and we also have much, much more. So this results in a decrease of the strength of this network. Another factor which is relevant for skin aging is the accumulation of advanced glycation end products. This is very famous, probably many of you know this in diabetes, but it also it is also relevant in skin aging. And this leads to a cross-linking of the collagen and elastin fibers. So the whole structure becomes stiffer. So it is less resistant, and at the same time it becomes stiffer. We have a generation of blood vessels, and this is not the only point. The point is also because of this thinning here, the thinning of the epidermis and the thinning of the dermis, although these upper and lower blood vessel system, they are much nearer to the skin surface, so they are more vulnerable to be damaged. Altogether, this results in increased stiffness and a decreased elasticity, again, especially in photo-aged skin. And this probably also somehow explains why skin tears usually are found in skin-exposed zones. What is relevant? Why is this a problem that the dermis becomes stiffer? As always, if you have soft biological tissues and they become stiffer, in the presence of mechanical deformation, it is easier for them to break. So the etiology was clear. It is mechanical force or mechanical loading. And if we have this impact here, we have usually a strong mechanical adhesion of the epidermis and dermis. So those areas are tightly connected, nothing will happen. Then a stretching of fibers takes place within the dermis. So, and it is quite resistant. And also there is a kind of viscoelastic sliding, viscoelastic deformation because of the fluid between the fibers. And this somehow can be compared with a cushioning effect. What happens in fragile skin? The same amount of trauma, and we are talking about minor trauma here. We have a weak mechanical adhesion of the epidermis and dermis, so it's much easier that both layers separate. We have a decreased viscoelastic deformation. So the dermis is thinner, it is stiffer, and we have less fibers. So it is easier for the fibers finally to break, and you somehow can compare it with a fracture of the dermis. So we have a separation of skin layers, and very often this goes along with a rupture of blood vessels. And this is also the reason why we so often observe this bleeding. And this is a whole range of clinical appearance explained by this pathogenesis. So skin tears, this seems to be rather a separation from the dermis and the epidermis, but always, as you can see here, this is associated with bleeding, minor bleeding, and what you can see here are events of previous bleeding. This can also be associated with rather strong bleeding, so the blood really fills artificial space within the dermis, and in certain cases also below the dermis to the muscle, and this is then called dissecting hematoma. Though skin tears or the whole etiology and pathogenesis, it is rather a whole area or a wide range of clinical appearances. I want to sum up. Etiology is easy in skin tears. It is caused by mechanical loading, and it's a rapid impact loading. So this is different to pressure ulcers, for example, or venous leg ulcers or others. The pathogenesis is the separation of the epidermis dermis or within dermal layer caused by trauma, by minor trauma. So also young people can develop skin tears, of course, but the amount of trauma, much more is needed. It is a fracture of the dermis because it becomes so stiff, and the viscoelastic properties are no longer present, and it can be associated with or without bleeding between dermal and subdermal layers. Currently, various concepts are in use, so including adhesive-related skin injuries, and unfortunately, it cannot be coded yet. Anyway, skin tears are strongly related to extrinsically aged skin, especially in lifelong UV exposure. And skin tears are a typical sign of fragile skin in the aged, and therefore we observe skin tears so often together with typical other signs of severe skin aging, such as elastosis or purpura, which I mentioned already. I would like to thank you very much for your attention, and if you have any question, I'm more than happy to receive an email, or we can discuss later. And thank you very much for your attention.
Good afternoon. My name is Julia Harris, and I am a tissue viability nurse at Imperial College Healthcare NHS Trust in London, England. I would like to thank EWMA and ISTAP for inviting me to speak today in this webinar series on the science and practice of skin tears. Today, I will be sharing my personal experience on pronation and the risk of skin tears in relation to COVID-19, and providing prevention strategies we implemented within my organization. I have no conflict of interest to disclose. The main objectives for today include sharing my personal experience working on skin tear prevention in the critically ill patient population with COVID-19, discussing strategies for skin tear prevention when nursing patients in the prone position, determine how to empower frontline teams to take ownership for improving skin protection processes when moving forward in the future. Imperial College Healthcare NHS Trust is comprised of 5 sites, with Charing Cross being one of its largest. It can be seen on the photo on the left-hand side and is located in West London next to the Thames. The photo on the right is an arrangement which was provided to the hospital staff by the local community for all of the hard work undertaken during the first wave of COVID-19. It really helps show support and appreciation for all staff members during the first wave of COVID-19. Redeployment during COVID-19. During the peak of the pandemic, the first wave, during April 2020, I was redeployed from the tissue viability team to critical care. At the time, there were 40 patients intubated and ventilated at Charing Cross Hospital, all with COVID-19. The ratio was 1 ICU nurse to 4 patients with bed buddies, which is where I came in. I have to admit, when I first arrived to critical care, I thought as a tissue viability nurse, I would have all my patients turned and skincare would be perfection. But I quickly had a big reality check as to what the situation was. There were a lot of challenges in terms of skin integrity, and this included skin tears when it came to proning. Patients were extremely unstable. Lifting an arm, repositioning would leave them unstable for hours. Proning at the time had rarely been seen. Patients proned could only be repositioned with an airway trained doctor present. Proning guidelines already established for our critical care did not address skin protection and preventative care. Patients were exposed to many medical devices at one time, including tape. Patients were prone for up to 24 hours at one time, for a total of 300+ hours during their ICU admission. And referral and incident reports, which were normally completed meticulously for the tissue viability team, were not being completed due to the increasing staff pressures. Evidence shows that individuals suffering from acute respiratory distress syndrome, including those arising from COVID-19, have a positive response to prone positioning. Prone positioning for at least 18 hours per day has been shown to decrease mortality among ARDS patients by increasing end expiratory lung volume, increasing chest wall elasticity, decreasing alveolar shunt, and improving tidal volume. Prone positioning presents multiple challenges related to skin integrity and wound prevention, including increased risk for skin injury in the form of pressure ulcers, device-related pressure ulcers, skin tears, moisture-associated skin damage, and medical adhesive-related skin injuries. In a 2015 Cochrane review, patients placed in a prone position had a 37% higher risk for developing pressure ulcers. We also needed to change the culture of the staff. There was always a large focus on pressure ulcer prevention and skin injuries taking place when the patient was supine, but now patients were being put in the prone position. So we had to change their thinking from back to front. There was a large practice evolution from the first wave of COVID-19, first seen in April 2020, to the second wave in January 2021. There was less intubation and more non-invasive ventilation. There was also more awake proning that was starting right away at admission through our emergency departments before they even arrived in intensive care. There was more preparation for patients prior to proning in terms of dressings and offloading devices. There was clearer documentation of when patients needed to be swum and head position changes with airway trained doctors present. And we were seeing this being written more and more in their documentation. There was a swift referral to tissue viability team, and all prone patients were automatically referred to the service. There was multidisciplinary collaboration between tissue viability and the plastics team in order to ensure skin damage did not become more severe. And there was also weekly catch-up between the tissue viability link nurses in critical care and the tissue viability team. So how do we prevent skin tears when proning patients? Some key points are to protect faces with liquid skin barrier wipes. Do not use spray around the eyes and the trach tie. Maintain proper eye care using ophthalmic lubricating ointment as indicated. And when taping eyelids shut horizontally, use silicone tape over fragile skin. If silicone tape is not available, consider covering the eyes with gauze and placing any tape on a prophylactic dressing. And applying cut pieces of silicone-based foam dressings on the forehead, cheeks, corners of the lips, chin, and under the nose, including any other vulnerable area the patient may have. During the second peak, we also established face protection protocols with visual imagery for the staff to be able to learn from. And this wasn't only the nurses working in intensive care, but the bed buddies, the subclinical support workers, and our colleagues in therapies. The proning teams were composed of physical therapists and occupational therapists, and they were key in ensuring that skin protection was maintained. Along with the visual guides, we also prepared proning packs for patients. They were kept in a designated cupboard that was labeled, and each proning pack had the prophylactic dressing in place, as well as a visual reminder to refer prone patients to the tissue viability team via the electronic patient record. These proning packs were replenished regularly by either the tissue viability link nurse or the therapies team. And I would also follow up and ensure that there was enough stock being supplied. We also relied heavily on our procurement teams to ensure that we had enough supply coming through, especially during the peak. I also set to work on establishing a skin tear pathway. There was a very clear clinical need that there was not enough knowledge amongst the staff in terms of prevention of skin tears, and as well as how to treat skin tears. And so initiating a pathway was extremely important. I collaborated with colleagues and with the support of ISTAP as well in creating a skin tear prevention and management pathway. It was meant to be implemented prior to COVID. However, due to the extreme demands of the pandemic, we were unable to continue with any outside education at the time. But after the pandemic had subsided, we were able to initiate the skin tear pathway and bring it into intensive care in order to really change the practice that we were seeing among the nurses. So having gone through the pandemic, there are some key learning points that have really stood out. Thinking between the nurses and other clinicians needs to change from back to front. The skin is extremely vulnerable after the patient has been lying in a prone position for many, many hours. There's a lot of edema, and in turn, the skin is very thin, very frail, very vulnerable. And so it's really important to ensure that the thinking changes. Patients placed in a prone position have a 37% higher risk for developing pressure ulcers on top of the risk they already have being in critical care. So despite everything we might do, there is still a degree of damage that might occur. Early intervention is key, being prepared with proning packs, ensuring the proning teams are aware of the guidelines and the protocols that have been established, having weekly check-ins, identifying high-risk patients in advance and ensuring a close eye is kept on them. Photos, if it's in line with your institutional policy, being placed in the clinical record in order to monitor deterioration and intervene as quickly as possible. Staff teaching on skin tears and prevention is required. This can be done not only in critical care, but anywhere within the organization in order to build the knowledge and ensure that the skin is kept safe. And multidisciplinary collaboration is a key to success. It takes the tissue viability team along with other disciplines, plastics, therapies, everybody involved with the patient to work together in order to ensure the best outcome possible for the patient. I would also like to bring to your attention a document that I collaborated on after the first wave of COVID-19 with nurses specialized in wound, ostomy, and continence Canada. And the document was released in May 2020, titled Best Practice Recommendations for Skin Health Among Critically Ill Patients, with an emphasis on critically ill individuals suffering from COVID-19. It covers everything from pressure ulcers to skin tears to medical adhesive related skin injuries to incontinence associated dermatitis. And this can be found on the nswak.ca website. Thank you very much for your time today. And if you have any questions, please ask.
Hi, my name is Hubert Voignard. I'm a physician currently working for the Wounds and Wound Healing Program at Geneva University Hospitals. I'm also a member of EWMA Council. It's my pleasure to share with you some thoughts on pain and skin tears. But first, no conflict of interest for this presentation. How can we define pain? Well, the International Association for the Study of Pain has given us this very long phrase, an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. In this very broad envelope, we can put the whole spectrum of all types of pain, which is a good thing. Why does pain exist? Well, it helps to prevent serious injuries or permanent damages. A slight touch to the fire will force a quick reaction. And then it will teach us avoidance. Usually do not put your hands twice in the fire. So it's a natural and efficient method, but perhaps not the best teaching one. How is pain generated? Well, you have an external painful stimulus. It will go up your nerve, spine to your brain, where it will generate the pain. That's very simple. When you see the whole picture with the numerous nerve endings you have in the skin, when you see all the substances that are released and play a role, when you see how complex the neuron works, how complex the spine and the brain is, then it's a bit more complicated. But let's stick to simplicity. Painful stimulus, pain. Pain and skin tears and other wounds. Well, now we have no precise data related to skin tears, and we will probably the field do further research. but from our clinical experience, we do know that they are painful. And we have plentiful of data on other wounds, and we see that the vast majority of wounds are at one time painful. Why should skin tears generate pain? When you think where the skin tears are located, which is in the dermis, in the epidermis, that's right where you have the skin receptors. And this can explain that it's a painful process for the patient. Then why should we consider treating pain in wounds as it's a natural process? Well, because it's an unpleasant experience, and it can be a very, very unpleasant experience. Because we know it diminishes the quality of life for our patients. Because we know that from acute, it can turn to chronic. Because we know that pain impairs wound healing itself. And because it's very difficult to treat a painful patient. To treat pain, we must be able to search for it, locate it, define it, assess it, treat it, and reevaluate it. McCaffrey said that pain is whatever the experiencing person says it is, existing whenever the experiencing person says it does. So it's very, very important not to forget to ask for pain and to observe for painful mimics, for example. And from the study we have, we are not all very good at this. We must also be sure that the person feels entitled to express herself about it. And it's very important. I worked in some places where you saw that patients were painful. And when you ask to our colleagues, they would say, oh, no, he's not painful. Why is he not painful? Oh, he doesn't say he has any pain. And you see the patient is painful. When you ask him, well, he says, yeah, I have pain. So it's very important. Then you have to locate it. Does it originate in the wound bed, wound edges, surrounding skin? Is it superficial? Is it deep? Is it generalized? Can it be matched with visual symptoms, for example, inflammation, pus? And then you have to define it. And we define two great types of pain. First one is a nociceptive, also called somatic. It's more linked to tissue damage. It's most of the time really easy to localize. The patient will have words like achy, throbbing, dull. And then you have the neuropathic pain, which is more linked to nerve damage or dysfunction, more difficult to localize, and the words used by patient will be burning, shooting, tingling, radiating like a fire, an electrical jolt, and so on. Then you have to assess it. When is pain present and which intensity? We have a tendency to say that pain can be a background pain, the pain that you will feel all day long. It can be incident or breakthrough pain. That's a pain that comes and goes during the day. It's usually a transient increase in pain intensity over background pain. And then you have the pain we are responsible for, the procedural one or operative one. And it really goes through the care procedure. And then you will have to assess the intensity. Up to now, we have no validated and widely used wound pain assessment tool, but we have many other tools that we can use. We have those for simple self-assessment, like the numeric pain rating scale, the visual analog scale, and the verbal scale, and then for children, the Wong-Baker-Facer scale. For cognitive impaired patients, we also have scales. These patients, they cannot express very clearly their pain. And it's our duty to go on and have an assessment that is clear and reproducible. You have here two of the most used one, the pain assessment in advanced dementia scale and the Dolopus assessment scale. Then you have multidimensional tools that will give you more information. For example, they will address what eases or aggravate pains, which are factors that we want to know. Among them, the McGill questionnaire is, but you also have the brief pain inventory, the initial pain assessment inventory, and the memorial pain assessment card. So when you have all these elements, you can begin to treat efficiently. Of course, the first step to treat wound pain is to treat the underlying cause of the wound, but it's not the topic of the present talk. Then you can say that you have two main categories of treatment, the pharmacological one and the non-pharmacological one. Among pharmacological treatments, you have them that will address the systemic nociceptive pain with molecules like paracetamol, acetaminophen, non-steroidal anti-inflammatory drugs, opioids. You also have the use of gases like nitrous oxide oxygen, the methoxyfluorine, and others. Then for the neuropathic pain, you can use gabapentin, pregabalin, antidepressants, anticonvulsants. For all these medications, you have to respect the dosage, the intervals, and the pharmacology. It's very important for them to be efficient and have less side effects. You can also use topical agents like viscous lidocaine, lidocaine mixed with prilocaine, ibuprofen foam, morphine gel, ketamine gel, and others. One thing that's very important is that you have to count at which time you will be able to do the procedure. You cannot give the medication and begin. Most of the molecules will take time to take effect. And in Geneva, we use this small graph. When it's green, you can go. When it's red, you don't touch the person anymore. Then the non-pharmacological treatments. Well, in general, you have to go in a calm environment, have comfortable settings to do the procedures. You have to be reassuring. You have to communicate around the procedures to be performed with your patient. You have to empower him. For example, when he says, you tell him that when he says stop, you will stop. So do not engage in a procedure that you won't be able to stop. The worst thing is to say, tell me when to stop, and then tell the patient, let's go a little bit, just a little thing to do. No, that's not good. He will remember quite well, and he won't be happy next time he will see. Then you can use music therapy, relaxation strategies, meditation, auto-hypnosis with some patients. Some colleagues use transcutaneous electrical nerve stimulation and acupuncture. More specific to the skin tears, non-pharmacological treatment can be achieved through a risk reduction program as described by ISTAP in 2018. You will clean and debride the wound with large amount of water of saline. Unless non-viable, you will use the skin flap to cover as much of the wound as possible. That's a fantastic biological dressing, and it's free. You will manage wound inflammation as inflammation results in pain. You will manage wound infection also. You will manage moisture balance, which is essential as desiccation is very painful. Then you must use non-traumatic dressing. You must change them as little as possible. You can use a skin barrier for the surrounding skin, the edge and a little more. When I say change them as little as possible, this doesn't mean you have to let them stick on the wound. You have to choose which one will be able to stay for a long time and not stick on the wound. If you use dressing, you will put a small arrow to indicate the correct direction of removal. This will allow the removal to be done without tearing the flap once again. You will go opposite to the direction of the tear. At removal, you can use adhesive removers, and you must use as much time as you can. Time is precious, we do know, but it's also doing things very quickly that can hurt our patient, and this is time lost in the future. Compression therapy should really be considered as for lower limb, but also upper limb with skin tears. It will reduce edema. In the edema, you have inflammatory molecules, and as I said, inflammation is painful. And then do not forget, when your dressing is on, to have a global skin hydration on the affected limbs, but usually also on all limbs which are prone to skin tears in our patient. So going to the conclusion, although we are missing specific data on pain in skin tears, it's quite of an issue. And with the aging of the population, it will grow up. And in order to help our patient, we must be able to define the pain, to assess the pain, to treat it, and to reevaluate it. And for this, we must give appropriate education to all healthcare professionals. Education is really at the base of the aim of better cares. At this stage, I wanted to thank you for your kind attention.
Hello, good afternoon, everybody. First, I would like to thank the EWMA for the kind invitation. And today I will talk about the knowledge translation into practice tips for using the ISTAP skin tear algorithm in daily practice and case discussion. I am Heidi Evia, Assistant Professor at the Universidad Andrés Bello and the ISTAP Regional Director for Latin America, one of them. By the end of this session, the learner will be able to identify the magnitude of the problem and population at risk of skin tears. Remember the definition of skin tears and skin flap. Review the ISTAP skin tear treatment recommendations based on the decision algorithm and apply the steps of the ISTAP decision algorithm to clinical practice. I declare no conflicts of interest and collaborate as a speaker for different companies, including 3M, SCT, Combate, Welland, and Molenke. Skin tears are a significant problem for patients and the clinicians who treat them. However, they are under-recognized, misdiagnosed, and poorly reported. Many clinicians have the misconception that skin tears are both unavoidable and trivial. It's just a skin tear. What are skin tears? They are wounds caused by shear, friction, or a blunt force, including removal of adhesive, resulting in separation of skin layers. The consequences of skin tears are painful and can become infected, affecting quality of life and causing distress to the patient and their families. May increase the likelihood of hospitalization and prolong hospitalization time, and they are challenge for professionals. The projected growth of the elderly population globally between 2015 and 2030, the population aged 60 years and over, it will rise from 900 million to more than 1,400 million people. This represents an increase of 64% in just 15 years, being the age group that grows the most. The percentage of the population aged 16 and over will go from 12.3% in 2015 to 16.4% in 2030. Although the situation of this region, it is different, Europe is and will continue to be the oldest continent in the world. The population at greatest risk are the extreme age, neonates, and elderly. Due to the increase of the elderly population and the vulnerability and fragility of the skin, I will focus the presentation towards this audience. In the clinical practice, this is the type of patient we will have to face. History of restraint, anticoagulant user, and poorly some degrees of altered consciousness or psychomotor agitation. This kind of patient, for that kind of patient, the ISTAP developed the decision algorithm. The International Skin Tear Advisor Panel defined the skin tear as a traumatic wound caused by mechanical forces, including removal of adhesive. Severity may vary by deep, not extending through the subcutaneous layer. And the definition of skin flap is defined as a portion of skin epidermis or dermis that is unintentionally separated partially or fully from its original place due to shear, friction, and/or blunt force. This concept is not to be confused with the tissue that is intentionally detached from its place of origin from therapeutic uses, like for example, surgical skin grafting. The skin tear decision algorithm is designed to help practitioners in the assessment and treatment of skin tears, maintaining a continuous link between prevention, assessment, and treatment. The aims of the treatment of skin tears are preserve the skin flap and maintain the surrounding tissue, reapproximate the edges of the wound without stretching the skin, and reduce the risk of infection and further injury while considering any comorbidities. The skin tear decision algorithm starts with assess and control bleeding, apply pressures and elevate the limb if appropriate, and use dressing to assist with hemostasis, for example, alginates. We continue assess the anatomical location, and 50 and 80% occur in the upper extremities. 15 and 57% occur in the lower extremities. We need to assess the cause that originate the skin tears, dimensions, length, wide, deep, and the wound bed. And this is, for example, a skin tear in the leg caused by the removal of anti-embolic stockings. And this is a skin tear in the buttocks in a patient with IAD and a precious injury where we do not have adequate dressings and fix it with different tapes. And then we need to document. Continuing with the algorithm, we need to clean and irrigate the wound as per local protocol and remove any residual debris and hematomas, gentle pat the surrounding skin dry to avoid further injury. Assess the characteristics of the flap and the viability. If the skin flap is present but necrotic, it must be removed. Ensure that viable skin flaps are left intact and frail skin is protected. We need to approximate the wound edges. If the skin flap viable, reapproximate to use as a dressing is a key step, and preserve the flap and roll it back into place where possible, using the glove finger, dampened cotton tip or tweezers. Ensure that the flap is in contact with the wound bed. And then we need to classify according to the ISTAP classification and document. Continuing with the algorithm, we need the goal of treatment is treat the cause, implement prevention protocol, and moist wound healing. This is a type 3 skin tears caused by restraint. We need to eliminate restraint practice and prevent or treat the infection. Here we can see some signs of infection. This is a type 3 skin tears. Educate healthcare on the proper selection of types based on clinical needs and adequate use of them. And remove the adhesive. Correctly assess and prepare the skin prior to application of adhesive. And this is a patient in the neonate unit. Use the lowest level of adhesive. Avoid using aggressive adhesive with heat-enhanced devices. And prevent self-injury and keep nails short. This is a patient that causes skin tear type 1 with the nails. And also we need to keep adequate moisture. Continuing with the goal of treatment, we need to avoid trauma and protect the peri-wound skin and manage the exudate. This is a type 2 skin tear caused by poor handling of the patient in the X-ray department. We need gentle in transferring patients or helping them in the daily activity of life. And this is a type 3 skin tears. It's caused by application of hydrocolloid to prevent precious injury. Choose adequate dressing, for example, foams with silicone, and do not use hydrocolloid and remove dressing carefully. And this is a skin tear caused by tapes, is in the same patient. Assess the peri-wound skin and protect from trauma, promote healing and prevent further breakdown, handle the exudate, choose the proper dressing and avoid desiccation. Continue with the goal of treatment. We need to avoid infection and pain control. We need to distinguish between trauma, inflammation, and wound infection. This is the trauma inflammation, and this is wound infection. Wound infection can result in pain and delayed wound healing. And diagnosis of infection should be based on clinical assessment and appropriate infection control measures taken. And we need to take tetanus immunization status. Some considerations are, for example, proper management of edema because contribute to delayed wound healing. For pain management, proper choice of dressing, such as non-stick silicone basin, reduces trauma and pain. Moist balance and exudate control, and moist balance is essential to promote wound healing and to protect the peri-wound skin from maceration, and offset the volume and viscosity of the exudate when selecting a topical wound dressing. And in dressing selection, the dressing must optimize healing and also decrease the risk of further damage in fragile skin. This is a case report in the day 0, skin tear type 2. We clean the wound with saline solution, the flap reposition and on a non-adherent dressing. Change the dressing on the day 5 and complete epidermis at 15 days. Reposition the flap and protect it when the bandage is removed and remove with the arrow. In conclusions, starting the appropriate treatment as soon as possible improves patient outcomes. Therefore, patients and caregivers should be educated to perform first aid when a skin tears occurs in order to preserve the viability of the skin flap where possible. And educate healthcare professionals, individuals, and families on how to prevent and properly treat skin tears. We would like to have the world without skin tears. Thanks. This is our reference and some resources.
Good day and welcome to all the attendees. My name is Annika. I am a PhD student with Professor Dimitri Beekman, and I am part of the Skin Integrity Research Group at the Ghent University here in Belgium. Now, prone position ventilation has been utilized since the late 70s, and it has been proven to be an effective therapy for patients with acute respiratory distress syndrome to improve oxygenation and also to improve survival rates. We have seen now during the pandemic that there has been an increased adoption of using prone ventilation to help the patients. COVID patients very often develop ARDS-like symptoms, and when it gets to a moderate to a severe state, then prone ventilation is really effective to help the patients with survival. Unfortunately, prone positioning is not without harm. We see quite a few adverse events as listed on the screen, but of all the adverse events, your airway obstruction and pressure ulcers are the most prevalent. From a meta-analysis done already in 2014, we see that pressure ulcers account for about 34% of all your complications. We see from recent studies that most of those pressure ulcers are also actually in the facial area and also related to your medical devices. We don't have a lot of data on skin tears specifically or on moisture-associated skin damage for those patients in the prone position. But we know that skin breakdown for the patient lying in the prone position is quite a challenge. Our risk areas for skin damage are now different. Our vulnerable pressure points are now obviously on the anterior surface of the patient, as indicated with the green bubbles that you see on the screen. And of course, your medical device related pressure ulcers are everywhere under or around medical devices as the patient is now in this position. We still see moisture-induced skin damage or moisture-associated skin damage, specifically because when the patient is in the prone position, you have an increased amount of respiratory secretions coming because of gravitation. And we see a lot of moisture-associated skin damage on the chin, on the neck, and even up to the chest area. It includes also incontinence-associated dermatitis, if the patient would be incontinent, and skin tears. When you use an adhesive and it's not silicone-based, for example, then you do have a risk of skin tears. And also with the maneuvering of this patient from supine position to the prone position, it's added mechanical forces that would then increase the risk for the patient developing skin tears. Now, these two pictures were taken during the first wave of the COVID pandemic, when there wasn't necessarily a trained team. Clinicians were not used to putting the patients in the prone that often, prone position. The patient on the right, he was in the position for 16 hours, critically ill, and unfortunately during this time the pillows used to offload moved, and that consequently created unstable pressure ulcers on its chest. We see skin tears from the tape, as I have mentioned, and the moisture-associated skin damage. And when we look at incontinence-associated dermatitis, you might not necessarily see the skin damage immediately while the patient is still in prone position, and only when you turn the patient back to supine. That is why it is so important to first prophylactically protect the skin from the irritation, from the incontinence, before we see the skin even being red when we turn the patient back. Now, us as a skin integrity research group realized that it is necessary to do a comprehensive review and a gap analysis of what is actually available for the clinicians in terms of educational material, what equipment, devices to use, or what is there, what protocols are there to help the clinicians to minimize breakdown for these patients now being placed more often in prone positioning. With this gap analysis, we established an international advisory board, and the experts helped us to then develop recommendations, as it was very clear that we needed to provide the clinicians with a practice guidance document, a simple document to guide them through the processes, make some recommendations from the literature and from the experts on areas where to pay more attention to put it like that. So that's why we developed this practice guidance document. It's called Protect, Prone and Protection. And it is a real simple document, only a 3-step process of preparing the patient, repositioning the patient, what to look out for, then management and checking of the patient's skin, and at the end, a short checklist that can be used electronically or paper-based to just focus on those areas to see that nothing has been missed. It's available for free download on our website and also available in those languages. And just a few slides to point out some highlights from the literature. The efficacy of prone teams has been well established in the literature, as to have the trained, experienced personnel, if available, maybe from the operating room, using the multidisciplinary team, the physiotherapists being experts in positioning, looking after staff safety. Because of this maneuvering, obviously the clinicians also needs to utilize equipment that is also safe to them, and experts that can look at how can we prevent skin damage from happening. Positioning the patient specifically to avoid brachial plexus injury from the shoulder area. So some suggestions on that, and really to look at your devices available, your turning and positioning devices, but also being careful that when using the equipment, or maybe it's just a sliding sheet, to make sure that we don't cause skin tears for the patient. Concerning our medical device related pressure ulcers, which we have seen in the literature is a huge problem, is to really replace the endotracheal tube holder, because that hard plastic, when the patient is now in the prone position, which can cause more pressure for the patient, and rather than use ET ties or tapes. If we are using a tape, clean the skin, clip the hair, don't shave, and protect from the adhesive. Because remember, with the ET tape securement, you need better securement than what a silicone tape can provide. Therefore, it's very important to first protect the skin before we put any tape onto the skin, and rotating those tubes often. From the Prepare tab, we really looked at the text you can see in red to look at medical device-related pressure ulcers, MAST, IAD pressure ulcers, and also skin tears. For skin tears, moisturizing the skin twice daily, quite important, and sometimes quite often overlooked in the critical area because of so many other things to be focusing on. So really just to remember how important it is to moisturize the skin to prevent skin tears from happening. The second and third page is really talking about more your equipment and your devices, but seeing what is available to your institution to help with the correct turning and repositioning of the patient, managing and then checking your patients. And the checklist at the end can then be used separately, maybe part of the patient's notes, to just make sure, did I look at those steps for the prepare phase, positioning phase, and the management phase of the patients. And what I want to highlight here, what we often see in clinical practice is that clinicians would sometimes wait until they see the skin is red, maybe from moisture, from the moisture we spoke about, or the incontinence, but maybe to focus on that prophylaxis, to use an alcohol-free liquid barrier from the beginning, because we know there's going to be moisture damage from the secretions, or if as soon as the patient is incontinence, fecal incontinence, then to already protect the skin before there's already irritated skin. And of course, referring to ISTAP and their guidelines available for skin tear prevention. Our research group is now going to conduct interviews with clinicians, both in Belgium and also our Swedish team, where we have a collaboration with the Skin Center for Skin Integrity from Örebro University, to understand what other educational tools are necessary for the clinicians to further prevent skin breakdown for the patients in the prone position. With that information, with the literature, again, utilizing our experts, would then be to develop an educational and training package, which we can then pilot test, first in a simulation environment and then in a real life ICU. At the end of the day, it's all about improving the quality patient care as much as we can and preventing the skin breakdown for the patients in prone position. Thank you.
We'd like to thank all of our panelists for providing us with such great presentations. And we're pleased to say we now have everybody here with us live. So we're going to move into some questions that have come in from you in our chats. And I've made a list of some of the questions that have come in. And I'm going to start with one that I think is pertinent to a lot of individuals. And I'm going to start to answer it, and then perhaps Hubert and Jan, you can jump in. One of the questions is around, why do we not have ICD codes for skin tears? And I would like to say that the International Skin Tear Advisory Panel is working on this issue. We were successful in the last round of ICD codes, so the ICD-10 codes, to get it skin tears as a sister code or a child code under skin lacerations, which is not ideal. However, it is better than not having a code at all. Jan and Hubert, do you want to one of you maybe want to pop in and give a little bit of more insight into ICD coding? Hubert?
Well, I think Jan will be better than me, but you know, in this ICD coding, there is so much competition on one side, and the concept of skin tears is so young, so it's a bit difficult to enter, I guess. The other thing is that in many reimbursement systems, these types of injuries are not very much reimbursed, so nobody gives a damn to it. I don't know, Jan, if you have another more scientific insight.
It's a good question whether classifications are scientific. No topic for today. So no, I haven't actually. So probably what I do know is that in the WHO different regions, there are local adaptations. And since now officially the ICD-11 has been launched, so that which does not mean that it is implemented everywhere. So it will take until all the translations have been performed and implemented and so on. So my first recommendation is to focus on the ICD-11 from now on. And still, and there are different task force and there is a dermatology task force from the ILDS, and I think they would be the ideal persons. And we worked with them a lot regarding IAD and pressure ulceration in the past. So I'm more than happy to help because I know all these people and we have projects together.
Great. Well, we're going to bring you into the ISTAP fold then as we move forward. So
you're welcome.
Getting into some of our more clinical questions that have come in. Jan, I'll keep you on just in the hot seat for a second. One of the questions was that, you stated that many skin changes relate with skin tears. However, most people always think that age is a major risk factor. And you had stated that it's not so much age, but the skin changes associated with aging. Can you elaborate on how we can manage or prevent skin changes associated with aging?
How many hours do we have? Well, yeah. So a simple answer is do everything what you usually would do to stay healthy. So avoid sun exposure, eat a lot, have a healthy diet, sleep enough. And this, what is true for all organs, it's also true for the skin. So this is a simple answer. Of course, there may be special, let's say, primary or secondary preventive measures. So the best one is sunscreens, for example, but which is also obvious. So, but the question you are actually asking is a tricky one. It's not aging per se; it's primarily extrinsic aging. This is for sure. So extrinsic aging caused by UV exposure, smoking, tobacco use, and also environmental pollution. So these are the three main environmental extrinsic factors. So whether you can avoid them or not really is a matter of debate. But this is really something that damages the skin and makes the skin susceptible to all kind of, let's say, injuries, risks, susceptibilities, and also the skin tear. So the skin tear is easy. It is a wound caused by trauma, but the susceptibility increases if all the other things are present. And of course, we also have a lot more, so medications, steroids, and so on and so forth.
Excellent. Thank you for your insight on that, because that is certainly something that, we struggle with all the time. So it's great to have some extra insight. Julia, I'm going to put you on the hot seat now. And you talked about the prevalence of skin injury in prone patients a little bit. Can you give us an estimate of what you think the prevalence is for skin tears among prone patients? You're on mute.
An estimate, to be honest, I can't give you an exact estimate. I think it's an area of research that needs to be more focused on to get an exact number of what is skin tears. I also think a lot of times skin tears are wrongly classified as pressure ulcers, which might be contributing to the pressure ulcer statistic, but not exactly giving the true amount of skin tears present. But I would say from what I saw in my personal experience, there was a high rate of skin tear, mainly from medical adhesives that we saw in intensive care because of the edema, especially around the face. And clinicians just rushing in their practice. There wasn't a lot of time to spend in order to carefully remove dressings. And so there was a lot of self-inflicted skin tears being caused as well. So sorry, I haven't exactly answered your question, but I think it's an area that needs to be looked into further.
I think you answered it perfectly in terms of we just don't know. So the challenge is for everyone to go out and start collecting that data. Hubert, I'm going to put you back in the hot seat. We have a lot of patients who develop skin tears who have dementia. And do you have any tips on how we can assess pain in the dementia population in relation to skin tears?
It's a difficult one. It's a very good question. It's very difficult to answer. As I said in my talk, I think we must really look for pain. We must really assess it, and we have this hetero evaluation that we can make. Of course, it takes time. When you become an expert clinician, then you have some sort of bell ringing in your head. But we see that when we work with younger colleagues, it's a bit more difficult. And then there can be a mix-up because you have pain and anticipation of pain and anticipation of procedure, and everything mix in this patient. So you must be very careful and try to dissociate these things that in the end are associated to take better care of. Just 2 days ago, I saw an old lady who had tons of morphine. I'm not against morphine, but because she was whining during the care, and just being gentle with her would put the wine down, and we could begin to go down with the opioids, and she was going really better. So yeah, it's difficult, but it's something we have to keep in mind because with the aging of the population, then we'll have more and more people with cognitive disorders and problems like this. And then there is the other way around. How does pain influence the cognitive state of the person? And if you don't go against the physical pain in this person, then you will think that they are more cognitively impaired than they really are. So yeah, it's a balance. So I'm conscious that I didn't give an answer.
It's okay.
It's true too.
It's very good. And I think that I know what your next research project should be. Heidi, I'm going to switch over to you. And if you can look into the question and answers, there is a question that is written in Spanish. And it starts with para hydrate la pele, and I won't even attempt to pronounce the rest of it. So I'm wondering if you could find the question and read it out and answer it in Spanish for us. Are you able to see it?
No.
It's para hydratar la pele y proteger ustedes recomiendan los ácidos gracias anciales. Oh, and I'm not even going to attempt to finish it.
Ácidos grasos hiperoxigenados.
So what I'll let you read and think on that, Heidi, and I'm going to come back to you on that one, and I'll come to Annika. Annika, can you maybe provide a little bit of insight into how you're able to differentiate skin tears from other wound etiologies, such as pressure injuries or incontinence-associated dermatitis?
Yeah, I think it all comes to assessment and the cause of the wounds. And with education, we can help then the other nurses to differentiate between it. And incontinence-associated dermatitis lesion can only be if a patient is incontinent. A skin tear, as you've heard from Professor Jan's presentation, with the mechanical forces or adhesives. So it's all to do with the cause. And sometimes it's very difficult to differentiate it if you don't have the patient's history, if you don't have the cause. But you will be able to assess the patient just by looking at the wound. You can get some clues, like we've seen with the different classifications of our skin tears. You can get some clues of it, or if you see there's a lesion on the perianal area and you didn't know if the patient was incontinent, it gives you some tips but it all boils down to proper assessment and the history of the patient. What caused the wound? That is the only way that you can actually differentiate between the types.
Excellent, thank you. And Hubert, one question back to you, because there's a lot of questions in the chat around moisturization. So in terms of how often should they be moisturized, what kind of moisturizer should be used, and any other tricks you can have around moisturization.
Well, yes, I think moisturization is something that we must always keep in mind. And we have good experience, and we are not the only one, with moisturizers that we use twice daily. Then the question, which moisturizer to use? Well, the one you have, mostly. We use currently in Geneva a mix of paraffin, of Vaseline, and glycerin, because it's easy to use and it's cheap, and it's reimbursed by most insurances. And sometimes it's the thing that you have to do. In some other countries, you will go to the supermarket and use moisturizers from the supermarket. For example, in the US, Costco, which is a big, some sort of wear thing, you get the moisturizers there. Then you have the things that are highly priced, all these hyper-oxygenated oils and things like this. To my knowledge, there is not much science behind. Concept, yes, but proof that it works, not. In Geneva, dermatologists have been working on a mix of hyaluronic acid and retinaldate, and they seemed in the laboratory and on the patient to be useful to boost fibroblast replication and production. Now it's sold mainly for the face in the anti-aging categories, and it sells about 1,000 euro a liter. So most of our patients won't ever be able to buy this. There is another thing that we use that's very old. It's not commercialized everywhere. It's called Angontolon, and it's halibut oil with derived vitamin A, which more or less is of the family, well, retinaldate is also derived from vitamin A. It's very cheap. It's very useful, but it's a bit, the consistent is a bit like Vaseline, petroleum jelly, and people don't like it very much. And there is some little smell of halibut oil that's covered by vanillin, so you don't know which one is the worst. But we have the feeling, we haven't seen into this, that the skin will get more firm, a little denser clinically, but it's, you know, it's clinical reports, no more. So yes, we must moisturize as much as possible. I just wanted to say, and probably Jan already said this, but the beginning of skin tears is not when you have skin tear. It's probably when you have your first sunbath as a kid. You can make a parallel between the onset of osteoporosis, the onset of cardiovascular disease. It's not when you break your bone that you have osteoporosis. It's ways, years before. The same with cardiovascular disease. When you have your heart infarct, you have been sick for 20 years. And the problems we have with skin tears, that we are in a phase where we cannot do primary prevention anymore, but still there is space for secondary and tertiary prevention.
Yeah, very good point.
A very good message to probably finish on, Kim,
yes,
perhaps just in view of time. So is that okay if we bring the session to a close now?
Yes, so thank you to all of our panelists.
Yep, thank you, panelists, and thank you, Kim, for all the questions. So we would like to thank you all for taking part in this webinar. Don't forget, you'll be able to access the video recording of the webinar on demand via the EWMA website within a few days. and also subsequently on our Skin Tears website as well. We hope that you will join us for one of the next EWMA webinars. The second webinar on the prevention of skin tears will be held on the 25th of March and will expand on the topics addressed today. We'd also like to bring to your attention the Journal of Wound Management, which is the EWMA journal. We're calling for papers on the current advances in risk assessment, prevention and treatment of skin tears. And the submission deadline is very soon. So that's the 1st of February. So please get your submissions in. You can keep yourself posted about future EWMA webinars via the EWMA newsletter, our social media or website. Thank you again, stay safe and have a good morning, good afternoon, good evening, good night, wherever you are in the world. Thank you all for joining very much and goodbye.